one of the things that we talk about with immunotherapy oftentimes are biomarkers for response, right? In colorectal cancer, we're always looking for MSI high. Even for cancers, like lung cancer, gastric cancer, we're, have the CPS score and a lot of debate, right, in those diseases. Tell us, what you think about biomarkers and immunotherapy in the HCC space, right? Because it's unlike some of the other diseases that I just mentioned.
Yeah, I think, and I think this is a question which will become even more important, right? We see the Morpheus study data where the TIGIT antibody, there's a more immunotherapy drugs that are coming and hopefully into the, area or the realms of treating HCC in future. But I think we wish there was a good target, like really that would be amazing. PDL1 scoring, or how you do the CPS or TPS, which is the most recent one that they used in the esophagogastric study, which I have no clue how to interpret or convert. But nonetheless, these are all. But for HCC, unfortunately, these really have no by its significance, either prognostic or predictive for immunotherapy. And as a result, we cannot use them. People had thought about like having a viral etiology versus a non-viral etiology, maybe a responsive, does that respond better to immunotherapy versus not? Even that hasn't panned out at all. So I think there is an ongoing, look for what is a marker, but I don't think there is one yet that we can go by. And it's
I agree. I think it is still, to this day, it's a one-size-fits-all strategy. That's obviously not what we want in cancer medicine, but at the same time, it does make things a little bit easier when prescribing these drugs because, correct, I mean, I don't think that there is really that novel biomarker that can predict response, but obviously this is a rapidly evolving field, and we would love to see, right, a biomarker of response come out that we can use. But right now, I agree, there just isn't much. When it comes to, we had kind of touched on this, right, with your prior question, but when you think about sequencing our patients, and again, really great that we get to even talk about sequencing therapy for patients with advanced HCC, but, just maybe a couple of comments on how you think about sequencing a newly diagnosed patient with HCC and how you might line up backup options in a second and third line setting.
Yeah, I think that is, I agree completely with the idea that we actually think about sequencing, and that's like a huge win compared to when I finished my training, right? I think I haven't prescribed sorafenib in the past 3 years, and which is amazingly different than how I was, where literally all I gave was sorafenib long time ago. So I think so we have come a long way, as we talked about. I think pretty much every patient. Most patients get immunotherapy combination as their frontline option. Unfortunately, there are a lot of patients who are Child-Pugh B7 or high, like they have unfortunate competing risk factors from cirrhosis and a decompensated liver failure along with HCC, where it may be tricky and difficult to administer immunotherapy in them. So that's where you may use a TKI first, or nivolumab as a single agent. It's still something we use all the time. But in general, for most of my patients, immunotherapy doublet doublet immunotherapy or IO plus VEGF becomes my frontline option. And then once they progress, we move to a TKI. The choice of TKI, is it lenvatinib or cabozantinib? These are the two that I think about as the most likely ones. My personal preference is lenvatinib. I'm just much more comfortable. It's actually slightly better tolerated than cabozantinib, is how I feel. And less thrombocytopenia, which is usually a problem in patients who have cirrhosis. So I tend to use lenvatinib first, and then and then progress. I've even done cabozantinib. I've yet to use regorafenib, but that's an option too.
Yep, I agree, and I think that that's kind of how I approach these patients. And wild, right, that we now think about immunotherapy as that frontline option, and then we can use some of these tyrosine kinase inhibitors on the back end. And then obviously, like we had talked about before, ramucirumab really is, it is truly a second line option that's been proven in clinical trials for patients with elevated AFPs. But at the same time, if they've received bevacizumab before, is usually not a drug that I go to.